So our vision is to create a inspiring and empowering public health ecosystem. That is to take up the public health research in the form of strategic knowledge development and capacity building with the context sensitivity. At the same time, we have to be human centric. That is, we should not be more corporate, and we have to be public health system oriented so that it can be applicable to the every sector of the population. So our main objectives is to support and strengthening of the health and development efforts undertaken by government and other philanthropic organization in the form of implementation research, whereas the national program implementation, research, monitoring and evaluation. And during the disasters and other things, what are the startups taken, studies we can taken for the preparedness, and we disseminate knowledge and evidence for the stakeholder awareness and for development. And to whether in local context initiatives, that is our strength. That is mainly we will regional specific context is research we are taking, and various health startups. What are the startups? We are doing various economic evaluation. Like nowadays, whenever any new intervention comes, they have to clear something called HTA. So we are helping the startup companies in the process of HTA. And this is our approach. We collaborate with various people, and we are mainly in program monitoring and evaluation, and evidence sharing, capacity building, and policy advocacy. And also, we are doing the evidence synthesis in the form of various workshop through systematic review, meta-analysis. Currently, we have taken network meta-analysis and umbrella reviews also in the process. So this is the level, our relevant focus areas: newborn and child health, adolescent health, maternal health, geriatric health, rare diseases, cancers, mental and well-being, nutrition, and environmental occupational health. So these are some of the activities we have done during the COVID. We have the various studies, and that can be done, and we disseminated to the policy holders. And these are the other our activities. So this is our network of our council with various organizations all over India. So these are the webinars and trainings we are conducting along with the various associations of India, Indian Association of Preventive and Social Medicine. And we have a workshop on research methods, leadership, protocol writing, and grant writing. Recently, we conducted in LLRM Meerut, and a lot of other future programs in the form of evidence synthesis workshops are planned to be conducted all over India. So we have internships programs from the various organizations also. And with this small introduction, we are also engagements with various organizations and ISLM also. So with this small introduction, we are moving to the panel discussion. I will explain the small introduction about panel discussion. This is going to be example of how to do a qualitative research. You all know very well quantitative research. We prepare a questionnaire, you circulate and get the data and analyze. Now we are going to, it's going to be panel discussion only, but I am going to demonstrate in a little better way that how to do a qualitative research, so that it will be easy for a two-way. I can teach public health, at the same time I can teach on research methodology. At the same time, we can go the panel discussion, so that it will not be boring for you. Okay, so thank you. Going to do is, we have the topic called how to upscale the lifestyle medicine in India. What are the challenges and solutions? So we are going to do something, a kind of focus group discussion. So that is actually the technique name, which is you commonly used in qualitative research. So what we are going to do is, we are going to discuss the questions. Actually, I will pose the question, and the discussion will go among the experts, stakeholders or experts. And we are going to form a theory that is called grounded theory. So as a usual thing of qualitative research or focus group discussion, recorders, people should be there to write what you're listening. But actually it's not there, so we are recording the conversation for you. Is it okay for you, sir? So that is a normal procedure you do. Get consent from the people to record the session. Some people say don't record, means you should expect them the decision also. So thank you so much for the consent. So with this, we will start the discussion. Focus group discussion will go like that. I will post the domain. You are going to give the reply. That will be converted into quotes. That is a research. So as a practitioners of lifestyle medicine in India, what have been the most significant barriers you encountered in integrating lifestyle medicine into your allopathic system? So, and how will you navigate these challenges?
So first and foremost, the community needs to know that there is lifestyle medicine which can help in management, prevention and reversal of a disease. So for that, initially we were not aware about how to go about it, but now I am practicing at Vadodara, Gujarat. So we have taken up this with the Family Physician Association. We are also approaching the corporates. So for the corporates, in the corporates, they have celebration of World Heart Day and World AIDS Day, and they have specific days where they allow outside people to come and give sessions. So that is our entry point into the corporate world, where we introduce lifestyle medicine to the clients, where they may be prospective clients who might have some risk factor. And then they also have the yearly checkups, the clients at the corporates. So when they do their yearly checkup, we give them this option of taking up lifestyle medicine as a part of treatment of their diseases, whether it is hypertension or diabetes or high cholesterol. So we offer them that along with your medication, which they are more convinced to do, you can take up lifestyle medicine. Now, once they enter into our system, we gradually, first we introduce them to all the pillars, and then each pillar we take in detail over a period of 3 months. That is how we approach. So the barrier I face over here is that first there is reluctance in coming to the LM clinic, but once we meet them often, like we try to go at least twice a year, and we are on the social media, so we keep putting out messages on the social media. But once they come to us, there is some reluctance about the nutrition part, especially with the dairy, because in Gujarat there is more dairy as compared to non-veg and eggs, and refined foods. Refined foods is a big barrier for us to get it out of the system. In the nutrition part, refined and processed food is our biggest barrier. For each pillar, we have barriers, which we gradually try to. Our main purpose is to give the education. Once the clients have the education and awareness, they become more receptive to our changes.
Okay, so you mean to say the awareness barrier is there. Okay.
See,
Yes.
so one is awareness barrier amongst patients, which Dr. Aarti has spoken about. I would also talk of awareness barrier amongst other doctors, other mainstream practitioners. I am anesthetist. I don't have a patient base of my own.
Very
So
good.
when I started my lifestyle medicine practice, the biggest barrier I felt was that from the other mainstream practitioners, because either they're not convinced about lifestyle medicine, they don't believe in it, and they're very reluctant to even refer their patients to you. So, having said that, creating awareness, creating conviction amongst other specialities, and also introducing lifestyle medicine as a policy at the level of medical education would really help overcome that.
I will send patients in Delhi. Okay. So,
Little exceptions. I'm
No.
saying this. He's telling that you were telling the tip of the iceberg. Actually, it was.
yeah, what I was looking into is I come from the health capital of India, Kerala, and we have a primary care system which is run by the government, and they run NCD clinics, and the paradigm on which they run is entirely different. They do not look into lifestyle modifications. I had personally been there. I'd seen what happens. They give prescriptions and they do screenings. They do screenings. That's a good thing. But the bad thing is they just evaluate blood parameters and keep adjusting the dosages. So I think that for me in my place is the biggest barrier. That is, this needs to come into the primary healthcare system, whereby they understand that this is the modality to treat chronic diseases, augmented with medications. Right now, it is only on medications, at least in my area where health centers are more prevalent and more.
So in cut short, sir, madam told about awareness barrier. Your barrier is mainly on the. It's almost like awareness barrier, no, sir?
No, it's not about the awareness. The system is placed in such a way.
Yeah, system is not awareness about like that. Shall we take, sir?
No, what I say is, yeah, it is an awareness problem, but the system on which the majority runs.
Yeah.
I would just like to,
Yes.
I would like to add that people think that doctors are there to prescribe medications. They
Okay,
don't know
okay,
that they are
okay.
there to de-prescribe medications
Yes.
also. It
Yes.
takes them by surprise, So that kind of awareness.
Very good.
barrier.
Because we also see our interns like what you come metformin. Test 30 days metformin. What? Nickel pretestinate. Why you refill again? Why you want to go back again? That's a very good point. Prescription level, health system level barrier. Second barrier we addressed. Anything to add to the barriers?
So the most common is so I'm working with the fully clinical department where the entire gastroenterology is there. So it's not that anesthetic. The moment we start integrating lifestyle medicine, the first barrier comes with the colleagues that you are doing something alternative or some wellness therapist. You are no more allopathic doctor.
Yeah.
So that is the
Stigma.
first thing I accept. And the second thing comes that how to implement in a corporate hospital. Again, they say we have a diet department, we have a psychologist department. So there is no interdisciplinary meetings happening which says that we are here for same cause, all specialities. They are doing conferences in different specialities separately, but the human body is one, and we all speciality has to come together. That is not happening in any of the conferences. So the organizers of the all super specialities, they are in their own zone. So I feel there is a lot of separation among the doctors, though we are dealing with one human being. Then comes the society levels, where the 80% of patient comes to the hospital that we are insured, and we can buy health and healing by money. So that is the thing which is happening at the industry level. And the fourth, I feel, is the biggest thing is at food industry businesses. That is the biggest barrier, because the social media, they are giving lot of bad information. So rerouting the patient, it takes 1 hour to make them understand that please live a normal life. And the normal is abnormal for them, and the abnormal is normal for them.
It's a very consumerism barrier. So, correct, consumerism concept.
I'll add on it. Just go to YouTube and try to see a recipe on a healthy plant-based diet. The first ad which comes is from Zomato.
Yes.
When the person is ready for LM, they are already with us. But to find a community for themselves, when the client is already ready to make LM changes, the acceptance by the family, when we go out for a function, go out for meals, it is very difficult for the patient to find his community. Like they would not find a whole food plant. I have not found a whole food plant-based restaurant in my city. My city is a big city, Vadodara. So to find your own community, that is a big, because there is no awareness, there are not many people catering to this kind of food.
Yes, but our comment of discussion is our barrier. So we can discuss about anything you want to add, ma'am? Because
I think basically education of the young minds.
Yeah,
We have
awareness,
posting at the social and preventive medicine pre-final year. We have to have dedicated clinics. I know I was posted at a PHC, and like you said, we were just prescribing medicines for headache, blood pressure, diabetes, etc. We need to have that model clinic where counseling starts early, so that early in the mind, so that when we evolve into clinicians, we handle the patients better.
So, yes, ma'am, but you suggested one point now. How can we elaborate into the solution of medical education? Because we know, ma'am, we can. I think you told the point now, ma'am. Medical education. How can we incorporate that? Because that is our doctors is first. You should make ourselves healthy, our community healthy. Let people come to the secondary, but we should make our community healthy. We are seeing lot of NCDs in our community itself, but they are not accepting that. It is not because of their lifestyle.
So we can start as lifestyle medicine physicians. What we can do is and we've been doing that, giving talks at various medical colleges, sensitizing medical students, and some of the students are a part of our society. So that is the first step, igniting the flame at the right time. But rest of the policies need to be made at a government level, wherein they incorporate this as a part. Yesterday, Dr. Ifeoma spoke of a lifestyle medicine competency being introduced when they're doing their family medicine competency over there. So some policies like this which introduce it at that level need to be made.
Do we say that CBME don't have such things? Competency-based medical education don't have such competencies in our setup.
Yes.
Even now only they're saying something called district level rotation internship. That kind of thing is coming. So it's a very good point. But CBME has to be wake up in that.
See, doctors are aware. Okay, I have 42 doctors in my payroll who are undergoing treatment with me for free. They are aware, but we have to look into how this can be disseminated into the community. Okay.
So we have started with the Family Physician Association,
Yes.
and our next group is the physicians of our city. So once they know about the concept, then all may not be convinced, but a few may be convinced, and then that cycle will go on. But again, as I say, it has to be first they need to know the concept, and then they need to accept it. So it will not happen in one time.
Yes.
It will take
It's a long-
repetition. Even for us, it did not happen in one time.
So we need to incorporate a competency in medical education to bring the lifestyle component for our community first. So,
I think as an ILM physician, we have to produce a lot of studies and publications so that our peer group can understand that this needs to be there. That is one thing. And in all specialities, we should try in all the organizations wherever we are giving talks, that the LM should be there as a speaker, so that the other specialities where we are talking on, they can understand to apply LM in the curriculum. So first, I would feel the colleagues should be educated. The influencers who are heading the specialities, they should be, because otherwise what happens, it's a pharma driven and therapeutics driven market, I would say. Sorry to say that, but it's 80%. My own head told me you will not get any sponsorships for any of the programs which you want to lead. So become an interventional endoscopist. So this is happening. All influencers are the people who are more pharma driven. So we need to change our mindset in our own department first.
so research into the allopathic system is another thing. I had a very good and bad experience with this research in this lifestyle on common. What is the treatment for dengue in Tamil Nadu? COVID no treatment. My papaya leaves. One more special drink in time. I speaking Tamil Nadu. No sir, we are correct. Nilavembu kashayam ande kabasura kudi neer illaya. Nilavembu kashayam. So when we did the research on that, it was presented in the ICMR Institute only. The research component has a lot of flaws. The randomization, the component, the allocation, concealment, everything has a problem. When we told that these are the research competency, the person who is principal minister woke up, who are you to address our system? Our system is our system. Your allopathy system. Don't bring your research into our system. I am Siddha. Don't bring your randomization component of giving Nilavembu kashayam to this component. That is how randomization is done in evidence-based medicine. And they are saying research itself is allopathy system. Our system is our system. Same happened with the papaya juice project in Karnataka. I don't want to name the institute. Now I can bold it as the institute because I don't have no connection with the institute. But this institute I have a connection, so I don't want to tell the name. They told that papaya juice increase the platelet is our system. Don't bring research into our system. Research is allopathy system. This is our biggest another shock for us. So giving these social cultural differences, how can we bring these interdisciplinary collaborations?
See, we need to have a common paradigm on which research will happen. This is the only way. This is like discussing whether there is God or no God. You will always keep fighting. One will keep saying there is God, one will keep saying there is no God. So we need to come to a common place where we can come to a 50-50 on how research can be done and what research will actually be considered veracious. That is what your way of data collection and the way you're doing it. At least yesterday, Dr. Ravi Mamtani was saying that what we are doing is not a reflection of real life. That is there. That component is there, but we need to come to a compromise if at all it can happen. Okay, if at all, because if the attitude is we know what we are doing, then it is not going to help. So if we can come to a consensus on how we will be interpreting and going on with the research, maybe because Risapine is an Ayurvedic drug. That is the first antihypertensive. We know that. But we were good enough to take out the molecule and make money out of it.
So that is another thing. Anything you want to add, ma'am?
So despite cultural differences, the education systems, the schools, from various culture, they go on CBSE or whatever mode. So I think sleep, physical activity, everything is the same. So though there are cultural differences, we still can implement these 7 pillars effectively is what I feel. And it won't be a big barrier because we just need to tell them you have to sleep well. And it can be implemented on a population if we have a well-devised system and a plan for it.
I would just like to add that cultural differences crop up only when the diet pillar is being talked about. Rest, all the other pillars, everybody agrees, and then you start talking about diet. So, how I navigate through this is that I focus more on what can be added to keep a person healthy. And then you start with the negative prescriptions because lifestyle medicine is also about building a relationship. It's a patient centric approach. And once you do that, then cultural differences and all become kind of secondary, and what becomes important is the health of the person. And then you're able to kind of go through the whole process. And it's very important that you keep those cultural differences in mind, because in the beginning, if you start going against them, then you've lost the trust in first place.
Ma'am, in that context, do we think cultural difference itself is a one barrier to incorporating lifestyle medicine? Because whatever I am telling will not be accepted in the Hyderabad.
No, that's what I'm saying. When you talk
that's
of the
another-
5 pillars, everybody agrees. It's when you come to the diet that people start talking about cultural differences. So we start with positive prescriptions first, what needs to be added, and they are very much in keeping. Fruits, vegetables, nuts, legumes. Everybody accepts them. It's about increasing their quantity. And then you start talking about what should be subtracted, and most people are open to that. Once they see the results in the parameters, once they see their labs improving, they are open to other things then.
So again, the cultural sensitive barrier is also there. We have
It is
another
there,
quote
but
in
you have to
this-
learn how to
because
navigate
Madam
through
also
that.
mentioned that the diet availability and affordability in
There is a
Gujarat,
huge
yes.
talking point there.
Yes,
No, I
that's
agree this. I had a real life scenario. I didn't know the Parsis only eat non-veg food. So I said the son that you eat now become vegetarian. And what I faced, the mother was a doctor, and she said, who's the doctor who changed the entire, we are eating non-veg since birth. So this happened, and I had to create small book. Now anyone comes, first read and then come inside, and then we can talk on further evidence based. When a doctor comes to me and when they have a no research is going on, it's a high protein diet and all. So it's the culture which sometimes it makes me little, what she said, first you give positive prescription, then
Yes.
negative. So my approach change according the patient, which religion he's coming from, which background they are coming, and then we start talking staged matched interventions what we
And
have been
also,
taught.
I would say that it's not about sticking to labels. The moment you start using words like vegan, vegetarian, non-vegetarian, there the problem starts. You use whole food plant-based approach predominantly, then it stays with the patient.
better term will be plant-based diet food. Don't label them. Labeling is another barrier to our incorporation of the diet barrier. Yes, it's-
And there is a gender bias also. If you're trying to cure the husband, the wife will say, no, this cannot happen. I cannot prepare food at this time. And if you're trying to treat the wife, and it is like, how do I eat alone? You finish your dinner at 6 o'clock. I should eat at 9 o'clock. No, so I get it. I ask them, what do you want? And they say, we both want to be healthy. Then I say, then you'll have to come to a consensus on when you're going to eat.
now we are coming with another going to family level barrier.
The huge barrier. See,
So-
once you start practicing, you'll understand this. Okay, they are ready to do anything for the children.
Yes.
But if it comes to the husband or wife, it is like, why should I sacrifice?
That is a design, sir. You cannot block the design. How can you block the design from Mylapore to Chennai? That is a design.
My approach is a little different. When the client comes to us, we take their ongoing diet plan
Okay.
and we just make it plant based. So he will not change what he is adding. We add some salads and some soups, but basic food to start with, we only try to cut out the dairy and make it plant based. If he's having chicken, we change it to tofu. If it is if it is using dairy, then we make it plant milk. So we don't change his timings to start with. timings,
So
or the
timing should not be
menu.
changed first. Okay.
We just, because it is a personalized
Yes. Okay.
one-to-one, so first we make it plant-based, and then gradually we introduce intermittent fasting, and if needed then juice fasting. But initially it is his own timings and diet plan which we are just making changes. So then acceptability, because all, like if somebody is working from 9 to 5, he would be carrying a tiffin, so we make changes in that tiffin.
It's a very interesting
That way-
solution. We need not change the timings actually. Actual timing is the best, but it depends on the family centric. Like Tara Zaminpar, they say every child is unique. Every person is unique in their concept. Again, will come in lifestyle. Again, cultural differences. Even in the state, there are a lot of confusions there. If in Kerala, Calicut people will not accept Trivandrum people. Chennai will not accept Thoothukudi people. Nasik will not trust Nanded people. Naklakram will not accept. I have traveled all the states to my God's grace. All the states I covered. I know the ethnography of each state, and it is shocking to me that in that culture, how can we incorporate the lifestyle medicine into that component?
even
Even
for
Gujarat
my
also, Gandhinagar will not accept though it is nearby, there are a lot of differences.
No, this is exactly
for-
why lifestyle medicine is very challenging in
Very
India.
challenging.
Very
This is
challenging.
another concept we have to address as in a ground level thing.
even for like those consultations which we do on Zoom and from other states, we follow the same procedure because it helps in for the client. It is easier because they cannot stop having their idli. We just change how the idli is made. They cannot stop their sambar, so we just alter
Yes.
the way it is made.
So a concept of community level prescription is coming now. Because prescription should be from them, not from us. In medical, metformin, glimepiride or amlodipine or the thing I am prescribing. But lifestyle medicine, again, prescription should be come from the patients. This is another sector to be explored in the lifestyle thing. Anything you want to add? No? Because
Yes, this is the thing. Like we have to ask them what you like,
Yes.
what vegetables you like, what fruits you like. Then they will say some names, and from that we can choose.
And that's why the lifestyle medicine consultations are long consultations. And the whole idea is to introduce health by minimally disrupting the schedules and then go stepwise.
In easy words, patient-centered care.
Yes.
We need to look into patients, their preferences, and try to manipulate. Okay, it's a big try, but it's worth the try. Okay.
One thing I want to add, sometimes we just start talking on diet and this and that, and patient is depressed. So sometimes we can't just send them psychologist last consultation. We have to become a counselor. First make them open that we are there for you, and they will listen everything and they will try to change. So sometimes the
Relationship
counseling comes the first, and then other pillars, I feel, when the mind is open probably.
So yesterday when we discussed with Rajendran sir, my teacher, he was told that one of the Spencer, they won't get rich card. But when they convert into rich card into another palatable, eatable, tasty form like beetroot chapati, which we normally do, it will become consumable. So they like to eat. So again, culture, patient level prescription is coming down. So another valuable solution from our discussion, we can find out that a concept of not only doctor based, we are coming out of the ego, and the patient level prescription is that can prove as a success in the implementation of lifestyle medicine. So go forward with the discussion that one last our panel, the panel discussion to come to the time. Have you explored any such successful thing of interdisciplinary collaboration and technology in lifestyle medicine till now? If anything, you can share because that can be a valuable point. Anything if not, no problem.
Yes, we are doing it regularly. Like we have a psychologist who would first, they also have free events who do online, everything is online. So free events where there will be meditation classes, there'll be yoga classes. In some events are free, and then the patient can enroll with payment. So even our sessions for those who are not in the city, it is on Zoom. It is through online.
So teleconsultation kind of it. I mean,
Yes.
teleconsultation.
Yes.
We can say telediscussion kind of thing can be done.
To add to that, we also teach patients how to use and interpret the data from their wearables and share it with us.
Okay.
So lots can be done in that because how to kind of integrate that data and how to collaborate with the doctor about that. we need not very expensive. We hope there are some kind of cheap apps for that, because even if we want to invest, at right now the investment is quite high for
Right.
all these things.
Yes.
And we are looking forward to a day when all this becomes not very expensive, because then that way we can practice lifestyle medicine more effectively and efficiently.
Okay. I think the technology is.
Yeah, telemedicine is according to me the future of lifestyle medicine. But right now we have a barrier that the first consultation has to be physical. So you have to meet the patient, talk to them, and then maybe you can carry it out in a telemedicine mode. That requires a lot of skill. I've been practicing telemedicine too, but not in India. I have clients in the GCC, and the results have been very encouraging, because it is patient centric in the sense that we do it when they are available. Okay, the doctor is reaching to the patient, unlike the normal conventional model where you have to wait for the doctor. There are platforms where you can, there will be slots for the doctors, which is happening, and it is a good thing to me, because anyone can put in 2 consultations, both
We
certified
know to
physicians.
enhance the passive approach. Now, active approach is passive approach should be that needs a lot of community level.
The good thing I'm seeing is the current lot of kids have it in them. They are very tech savvy. So you tell them this is what we are expecting, and we can do a Zoom call. I have a very good thing to share. I saw it in front of my eyes. We used to live in Chennai long back, and one of our tenants' son, he was 130 kgs. Okay, 130, and with no comorbidities. And I started him on an intermittent fasting regime alone. In 1.5 years, now I met him yesterday. He came to pick me. He was 85. And I was amazed by what I saw. I was literally amazed. I do this for a living, but I asked him how. Okay, and he was like, Anna, neenga solli thandadu naan. Okay, I was like, wait, tell me how. I want to know more. And he said, see, after the broad guidelines you gave me, I started individualizing things.
Oh.
This is the good thing with the current lot. Okay, maybe elders and people of
So we
my...
need to remove our thinking that current generation is not listening to us.
Yes.
That is our concept, no? I listen to I see only what my father channel put on my TV. Now you see only Peppa Pig. So that is your new current generation also listening to us.
They are listening, and they are more health conscious, and in a sense more misinformed.
Misinformed also.
No, we like in our setup, we share knowledge through YouTube videos, and it is very specific to the client. So first, in my interaction, I would tell that, for example, if I am telling about Yog Nidra or muscle relaxation, then I would share a relevant video, which is not either made by me. I have some content which specifically are made for my patients, either my video, or I would share something which is available on the YouTube which is relevant. So we do use this social media for patient awareness and for helping them tide through the pillars. Because see, when I tell you do eye exercises, patient will not know what exercises. So we share a video about eye exercises. So there is a lot of sharing on WhatsApp and email.
Social media based intervention.
Yes.
Community levels.
Yes.
Another way to reach the community.
You bring the family or who's cooking the food, because you can give 1 hour lecture, but it will not be implied. So if we can do a group family consultation, because we are giving the same time and the entire group is motivated. Maybe the patient is not motivated, but the caregivers or the family members are more motivated.
Family is a part of the society, so now we have started family itself. Initially we go for
Family also.
Now we are going for family.
We can say if you are free, maximum number can come in the one, so they are in the one group. So the entire diet is for everyone. It's not for the patient.
Got to say house is the male, the house is the female, so we can get the
Whoever is the dominating family.
very gender sensitive and cultural sensitive.
One more thing is we have these stigmas. Drop-in group medical appointments. Okay, this is very important according to me, and this stigma can actually be taken a step ahead by forming a WhatsApp group among them.
Okay.
among them.
Already we have a lot of
Yes.
Yeah, so that
husbands only WhatsApp.
no, all kinds of WhatsApp groups
all
are
kinds of
there,
WhatsApps.
but Digma group would be very good because they have similar problems. And the one advice I would give is you don't be the moderator or you don't even be in the group.
We always have group consulting only, where the cook is always present, and we give a written black and white email.
How
or-
ethically that is acceptable in the system? Huh? Because
Because,
my husband don't say this to my wife, sir, like that. Something say
No, lifestyle, all
So
the
no,
pillars.
that's I mean, because when you come to the concept of family level consultation, I have to reveal the certain secrets.
No, the consent
No, it
level
is
that kind
about,
of-
and
it
the,
is yeah,
and
it
the,
is about the nutrition and the exercise, where it is with the family, and after the consultation it is given in black and white, either through email. They have it written down so that they can go back to what we have prescribed. There is
In certain things you have to start with the counseling component also.
counseling, not for the counseling, for the pillars of nutrition, for exercise. It is with the family.
So the relationship building is with the entire family eventually. So we say patient centric, but eventually it becomes a family centric approach.
So I want to tell you that mind body medicine, it's not medicine body mind. So we have to understand when family comes, who is close, who is, so we have to give a group therapy, and then we can later part we can ask them, have an isolated consultation for 5 minutes. If you're feeling the patient is suppressed, depressed, he cannot express among the all family members. That could be the last part where I do normally. I say now I want some separate time with the patient. They express
We
more.
can go for educating the children, because we listen to children more than the spouses. So that is how we can. How can we address that kind of? Again, initially we in our discussion we started with the patient level prescription, then we went to community level prescription, then we went to family level prescription. Now we are going for children level prescription, so that it can be the future generations that they will learn, incorporate that itself in the.
see
program.
that is it. My hope, okay.
That is so, yes.
My hope, has anyone ever heard of the great manure crisis of 1894? Anyone in the group? History is a great manure crisis of 1894. What happened was, before we had cars, there were horses, and horses were the only source of locomotion. So there was dung piling up. Okay, 2.5 million pounds of dung piling up in New York and London. Yeah, and everyone was like, "This is the end. Nothing can be done. We need to move to places, but we don't know what to do with the dung." And they even had a scientific council meeting talking about ways to mitigate this. And suddenly, Henry Ford came out with the automobile. It was totally wide. No one was bothered about horses anymore. So this is what I see. Right now, we are in a place where we are so bothered about NCDs.
So seeing the positive in everything.
No.
another thing,
There will come a
business
time.
side.
There will come a time that this is what I hope, and we all should hope, that NCDs will be something of the past. We will know what is to be done. We are the Henry Fords. We have understood what should be done, and I think, okay, that's what let this happen. Artificial intelligence will have a huge role to play in precision medicine and lifestyle medicine. This is it. There will be algorithms which will be teaching us. There will be algorithms which is teaching us how to exercise, rather than we sitting and saying 150 minutes, 15 minutes of weight training. There will be algorithms which will be personalized for the weight, body, and the genomic of the person. And this is where this is going towards. We will be the pioneers, is my understanding, but we need to train ourselves in such a way. See, that there is a huge component of patient relationship, but
Okay.
the
So again,
patient,
say so artificial intelligence based technology.
yeah. This is where.
I feel that sometimes that I would have been in a forest for 50% of my week and 50% in the
Okay.
hospital. So we should first think that treatment is not only in the hospitals. We can do that in resorts.
That's what we are
wellness
discussing, the patient level prescription, that kind of socializing the medicine kind of concept is.
So first, we as a doctors, if we think of that perspective, which the wellness section is completely in the non-doctor sections, where we should also try educating people as LM physicians through live workshops.
Dr. Priyanka, what I understand is, okay, we are not superhumans. Okay, so there is a huge level of delegation which can be done. Okay, we need to guide. We are not going to go everywhere. I will counsel. I will take diet. No, we should supervise what is happening, because our resources are less, and there are a lot of people who know this well. Dietitians are there who know this well, but they are trained in a
Kind of, monitoring and evaluation component.
Exactly. We need to be delegating things which is not necessary.
So-
Sometimes we might counsel. Yeah, I agree with that. But we have to start it and let. There are people who are very good in cognitive behavior therapy, better than me. Okay, so that is the kind of people I want in the team, and that is the kind of approach we need. Maybe we'll put the spark,
Yes,
and the
we
fire
can
will be taken up.
submartin. So coming to the end of the focus group discussion we have done till now, we have find a lot of insightful solutions from the experts. So we started with the awareness barrier, we're coming to the medical education component, streamlining, and we have seen that 6 pillars how we addressed. We started a level of prescription also. Started with family patient level, family level, spouse level, then we are coming to the children level prescription also we have come. So we have come into the order solution. So this is how we are typical focus group, and we formed a theory of that. So thank you so much for the focus group discussion for the time make. So
Thank you.
Suppose you want to add anything from the audience side. So we have to respect that outside group also, because sometimes the new knowledge will come from that.
Thank you all for your immense knowledge and sharing with us. First is with the moderator that you did a focus group discussion, and in quantitative study we can see many things and we can balance, but how we can balance the bias here? That you only decided that this should be the quotes which I want, and this is completely biased. How to address it first? That's the first question. Then I'll come to the next.
We need to do next, after this we inform a theory, there is something called theoretical sampling. Suppose, what is a major barrier found out there? To discuss the whole thing, what is a major barrier you find out?
Awareness.
Awareness. So that from the awareness, I should do next few set of doctors for the another discussion. So the interview will go like that. Finally, a point of data saturation will come. So that will remove the bias.
Yesterday we had a concept somebody, after 10 patients they was repeating and all those things, they were
Saturation.
Yeah. So are you saying the similar thing?
Yeah, same. That is called data saturation. The same thing repeated. So theoretical sampling is one way to remove the bias in the qualitative research.
Yeah. But I don't totally agree with that after 10 or something, there should be enough numbers and it should show on the
but numbers is not the concept in qualitative research. Qualitative research involves a theory, transcript theory.
True.
Numbers is the concept only in quantitative research, where there is something called sample size, some says formula for V by D square, N1 minus N2 the whole square, all that nonsense are there. Because qualitative research will have only transcript. Thank you.
Yeah. Just one question I'll ask. Just one question. And are we competing with naturopathy, Siddha and Ayurveda in this?
No. I'll give an easier solution for what you asked. There's something called a Pareto's principle, the 80-20 rule. Okay, always follow that, at least in clinical medicine. It is easier. You go into the statistics, we know where this goes. Okay, 80-20 rule, and you will get what we have discussed right now and where it is going towards.
Thank you for the opportunity. Very nice discussion.
Excuse me, sir.
It was very informative.
Excuse me, sir. Excuse me. For naturopathy, Ayurveda and all, if you go into the genuine practitioners, you will find people who are practicing LM. So in fact, I did 1 year holistic healing course with a naturopathy institute during COVID. And what I found is that you will find your community there. You will find people practicing LM. You will find ways to implement LM in your practice. So we need to approach with an open mind because it does help in our practice. So and people will listen to you because you are MBBS plus, and they will have more faith in you, and you can at the same time implement LM the way they have done since years. So I think it is a positive collaboration.
Very interesting discussion, and we'll carry it forward, but we are running short of time. We'll just
Yeah, I just want to make one observation and one comment.
Sure.
I'm not talking about methodology of research and all that. Let the experts discuss that. I'm from USA. I do have a confession to make. I'm not very familiar with the system completely here. We have 1 million doctors in India. What percentage of them do you think are aware there's a specialty called lifestyle medicine? I would venture less than 5%. Less than 1%, thank you. I'm talking about our professionals. Doctors don't know that we exist. Yes, smoking was found to cause cancer in 1958. Billions were spent to tell and convince the public not to smoke. It came down to 50% to 15% in the US. What I'm getting at is we need to temper the enthusiasm. Change won't come. It will be centuries before people realize that the old way was a good way. Fast every 2 weeks, Ekadasi day. Our great grandmother didn't know the IGF and BDNF, all these are taking place in the body. Autophagy is taking place, but she knew that was good. We don't need a randomized clinical trial for that. That is just one example of it. We as doctors will take care and cure sometimes, relieve often, one patient at a time. You know who makes the biggest difference in the lives of the population? The policy makers and the politicians. If we really want to do some good with this, we need to convince the politicians that this is good. That's one aspect of it. If you want our medical students to know that this is a good way to treat the patients, we need to go to National Medical Council. Our friend is from Ahmedabad. He has access to it. Yeah, I have access too. That's where we should start. At least now we average medical students start 2.5 hours in the whole curriculum, 4 years about nutrition. They tell us the citric acid cycle, but not what to eat and what not to eat. They want to, what happens if the carbon goes away? There's a major question. Yes, you can eat all the meat you want. Nobody talks about it. So now time has come for us to talk to the policymakers, tell them this is the future of health in the world, not just in India. We just can't afford to have pill for every ill. We need to have change of lifestyle. Dear friends, one sentence. And please listen to the slogan, say it everywhere. Lifestyle medicine is easy to teach, easier to understand, very difficult to practice.
Thank you.
Yeah,
Last question.
just
Yeah.
last comment on that. Carrying forward from there, I represent a company which works in this space. As you rightly pointed out, the point that got missed out, in my opinion, is the knowledge barrier is there very much. However, people are becoming more knowledgeable because probably they are overloaded. The biggest impediment is in the behavioral change. The behavioral change doesn't come by just teaching them. It comes from regular monitoring, modification on a daily basis. Somebody sits in the table and says this table, and then they call up a relationship manager kind of a model that we have, where we say, can I eat this? And when I say no, they are able to keep it down. That level intervention, I personally believe doctors are not in a position to do that. So it has to come from other practitioners probably. The behavioral modification would be a great
there is a concept.
Absolutely. The
There-
point I'm trying to communicate is this needs the constant monitoring is going to be a very important change.
There is a concept of case managers which is there with us.
Exactly.
Yeah. So, and what I'm thinking is better than a case manager, you have your mobile phone, right?
Yeah.
You have an app.
Just one point. So the second point I just wanted to close it with that is when we tell people, rather than trying to point out perfect, getting them to a better has been the most useful thing that we have found in our practice. That's it. Thank you.
I'm sorry, we just have one more question from Dr. Herb.
I really appreciate all the input that has been given here today. We talked a little bit about barriers, and one barrier that I struggled with, and I'm looking forward to more answers, and answers can come to me afterwards, so we don't take up everybody's time. Part of the population that I also deal with is shopkeepers, and they go home at 10 o'clock at night, and then to eat and do whatever else and have their family time. We heard earlier about the barrier of time. Husband eat at one time, wife eat at one time. I struggle. How do I help my shopkeepers? I have a bank manager who was on 4 oral diabetic medications. He was able to get off of them, and he takes his tiffin to the office and eats his evening dinner at 6 o'clock. And then he comes home to his family at 9 or 10 o'clock. I feel like a failure because you also mentioned that relationships are so important. Here, he's eating at 6 o'clock in the evening in the office, and the family's at home waiting and wondering when he will come, and when he comes, what will happen to them. And around food is such an important social and relational time. What have you found works?
I just put it fast.
But that is hard for the family. You have children, you have wife.
No, intermittent fast. My children, okay, I've put them and they don't know this, okay. It's a trick. So they are likely on a 14-10. They don't know that, but it is well disguised. Okay, so it is quite possible if we have the knowledge. That is where we are all going towards. If we actually know that, and as someone was pointing out, earlier religious beliefs are all based on this. Not everyone is a doctor to know this, right? So if you have a spiritual principle which will take this through, it is fine. I do struggle with what you said. I can actually understand that, but I go through this. Okay, all of you fast. You'll have a good time.
So thank you so much for a wonderful panel. And I will request Dr. Rajendran to give a small memento to Dr. Sudhendra Kannan.